And a very happy good evening to you, America. My name is Dr. Randy Fink, and this is Fertility with Fink and Friends. I am Fink, you are Friends, and this is exactly where you are supposed to be every Tuesday evening at this time. It's 5 o'clock p.m. on the Gulf Coast, which means 6 o'clock on the East, 4 o'clock in the mountains, and 3 o'clock on the West Coast. And Fertility with Fink and Friends is where we are every single Tuesday, where we can talk about all those things that are important to us, things about, making a family, things about getting pregnant, things about staying pregnant, things about women's health, and all that stuff that you have on your mind. Many of our folks are going through fertility treatments now, and that's really what we talk mostly about. So if you've got questions for those things, throw them my way tonight. Oh gosh, as I knock the microphone out of the ballpark here. Great to see everybody. We've got some different different feeds going on here. This is my Instagram feed, Randy Fink MD. If you don't follow me, please do so. Here is some Facebook. We've got First Fertility. We've got New Life Fertility. We have the Missouri Center for Reproductive Medicine. We've got LinkedIn and YouTube right here in the middle. And this is New Life Fertility's Instagram over here on this side. I am a fertility gynecologist at New Life Fertility in Pensacola, Florida, with offices also in Panama City and Mobile, Alabama. And I also work with the wonderful Missouri Center for Reproductive Medicine in the St. Louis area, Chesterfield, Missouri, as well as their satellite office in Tulsa. So happy to see you at any of those locations. We can do that virtually. All you have to do is pick up the phone or the internet, give us a call, set up a time. Happy to talk to you about what's going on in your life, in your world, or for that matter, in your cycle, because that's what we do here. A special good evening to, let's see, who was first? Rosa. Guess what? You're number one here. Thank you so much, as always, for being here. That's Rosa SD. We've got D. Meyer. Hello. Priest Lana. Nurtured Shanna. Good evening, my friend. Abby Kadabi. How are you? My friend Noodles for Life. Hello. Ocean 221333. I know who you are. Let's see, Marlena, we've got T. Andre. Hi, how is good to see you as well. Thanks so much for being here. Dr. Hosa Melzani, I believe that says. Jessica, howdy. Hi, Sarah. And over here, we've got Jen Bader from the great place of MCRM. By the way, we are all part of the world-renowned First Fertility Network, and that is what brings us all together. Find us on the web at firstfertility.com. So let's see, let's dive into some questions over here. Abby says, when do you worry about a C-section defect? And do you check after every C-section before doing a repeat frozen embryo transfer? So what I would say is I do think before doing an embryo transfer, you definitely should have the cavity checked. How do we do that? We can do that with a saline sonogram, or what some call a fluid ultrasound. We can do that with a hysteroscopy, which is where the little camera goes inside to take a look. In my office here in Florida, we typically do a hysteroscopy because it's very easy. It really doesn't feel like much. It's a tiny little wire type camera that goes into the uterine cavity, takes a quick peek. You get to see it too. I frankly think it's really very cool to be able to see the place, kind of where your baby is going to grow. But so when we do that, we can see if that C-section scar has healed over or if there is an issue there. In most cases, I will tell you, it's really not so much an issue, usually not something that has some later effect on doing an embryo transfer. The place where the incision is made on the uterus at the time of C-section is what's known as the lower uterine segment. And the lower uterine segment is actually in the cervix. And so in the cervix, that's a spot that is remote from where an embryo is going to implant. Now, I have seen situations where scar tissue forms under that C-section scar and ultimately results in making the cervix difficult to traverse. And this is something certainly we want to know before we go placing another embryo inside, because at that moment, that embryo's thawed, that embryo's ready to go. So I do think it's incumbent to evaluate the uterine cavity. And in fact, I recommend you evaluate the uterine cavity really once a year, but certainly after having had a delivery, 100%. You do want to check that out, Abby Kadabby. Shanna says, can you please speak to short-term Medrol pack versus prednisone for an FET? I tend to implant, but followed by an early loss. Well, so what you're talking about there is using different types of steroids, corticosteroids, which are designed to turn down an inflammatory effect in the lining of the uterus. Now, the truth is there are actually very specific cases where using some steroids may be helpful when there is a known immune problem. But in general, the American Society for Reproductive Medicine says we should not be using steroids routinely in folks having an embryo transfer. Why is that? Well, they can contribute to, they make your blood sugar go up. It's not good for your adrenal glands. It really, is not something that you want to be on long term. Now, if you've done it before, I would say, okay, I think it's fine to do that. I know, Shanna, where you're having your transfer, pretty much everyone is put on steroids during an embryo transfer, even though there is no evidence that that is necessarily beneficial. So, the things that I would think about: implantation followed by early loss. I'd have to wonder about, the lining of your uterus and how that lining has been progestinized. I'd have to think about endometriosis, because, endometriosis opposes, it antagonizes or blocks the effect of the progesterone. And those things can lead to early losses. I don't know that prednisone would necessarily stop that from happening if it was going to. I think if there were an autoimmune problem that was causing that, I would think that would better be treated with tacrolimus or Prograf, but not what you asked. Is it okay to use that prednisone? Sure. I know they're going to, recommend it. They recommend it 100% of their cycles there anyway. But a Medrol dose pack is basically packaged so that you can start on it, and then it basically it includes the taper over the course of the week or 10 days. And really the most important time, it's thought that type of immune response, if there was an inflammation in the lining of the uterus, it would have to do mostly with right around the time of embryo transfer and in the few days after. So the Medrol dose pack is designed to suppress the immune response, to raise your own cortisol levels, which is your body's stress hormone, right around the time of the implantation. As opposed to something a little bit later, prednisone. So the way it used to be, now the way it's done typically with prednisone, if you're on prednisone, is that you stay on it until roughly about, call it 10 weeks, and then maybe you start to taper so that you're finishing it off in a couple of weeks by the time you reach the 12-week mark and out of the first trimester. So they really are designed to treat two different time periods. And I think they may have made a switch to go to a dose pack instead, just because it's really trying to treat right at the time of implantation rather than something a little bit later on and more of a prolonged immunosuppression that may not really be all that beneficial. I'm guessing that may be why they made that change, but that's kind of the difference in those two things. And so I think the question would really be, if that early loss, Shanna, happens, like a biochemical type pregnancy or kind of typically before 6 weeks, the Medrol dose pack really ought to be sufficient in suppressing that immune response. And you're just on it for not as long. And that's probably a good thing. But I would certainly suggest for you tacrolimus or Prograf under that situation, you know. Let's see who else we've got. Nessa over here. Hi, Nessa and BP Sullivan. Hi, Maddie. Good to see you here this evening. Jessica says, what is the process of moving embryos? We just moved to Pensacola Beach from Arizona, and our storage is due, but we want to transfer within 9 months to a year. So the way that works is that, your embryos are in all probability stored at an embryo storage center. So some practices will do prolonged embryo storage in their own facilities. Others end up sort of passing that on to facilities that have a little more space and might be a little more stable in terms of you don't have to worry about hurricanes and tornadoes and things like that, natural disasters that may kind of affect embryo storage tanks. And so they're sent off to storage facilities where you pay generally an annual fee, usually around probably $600-ish or so to store your embryos. Well, really all you have to do is once you have established care, if it's here with us at New Life, we will help you walk through the process of getting those embryos shipped. The shipping of embryos happens pretty easily. It's actually something that, there are these specialized shipping containers. They all go by FedEx. And so there are really a couple of different companies in the United States that specialize in shipping embryos. And they're almost, not quite yet, but almost to the point where they will kind of even have an escort with those embryos, which I think is great because you don't really want your, ship at FedEx. You don't want it accidentally left out on the tarmac in Memphis, for 2 weeks. But the truth is that those embryo shipping containers, those cryo storage containers, will typically keep things frozen for really up to 30 days. So it's very safe, generally speaking, to ship embryos. And the process literally takes like overnight. So there's not a rush to get them shipped. So you want to establish care. You want to figure out the timing of when you want those shipped. And I think if you're thinking 9 to 12 months, I think you're fine just leave them where they are for now and then, kind of ship them much closer to the time that you're ready to do your embryo transfer. I think you are going to love living on Pensacola Beach, except for the traffic during spring break and the summertime. That's the only thing. But boy, it sure is. Did you know, and I mentioned this before, you may know that Pensacola Beach was named the #1 beach in the United States, #1 beach in the United States by Travel and Leisure. And the #2 beach in the United States actually happens to be one beach over to the east of Pensacola Beach, and that's called Navarre. Both of these places are just astonishingly beautiful with white sand and just beautiful water and everything else. So Jessica, I am jealous of you for living on the beach, and I hope it was a great decision. If you moved from Arizona, then you're used to the sand, but I think your sand was very different than that nice white sand on the beach. But welcome to Pensacola. Glad to have you here. Let's see what else we've got. Maddie says, Maddie May, Dr. Fink, hi, Joe and I are hoping to have our first IUI with Simona in Panama City this cycle. Is there anything we can do to help support success? In fact, yes, potentially so. And in fact, I was just talking about you guys today. So nice to see you here. Thanks for being on the show tonight. So the first thing is there are really 6 supplements that I recommend for embryo transfer. This is an evidence-based protocol, and the evidence shows us that these simple little additions can make a difference in terms of success with fertility and embryo transfer. So now you're doing an IUI, so that has kind of more to do, or as much to do, with egg quality. And so let's talk about the egg quality things. Number 1, prenatal vitamin. Well, kind of that's a duh, right? Everybody knows you're supposed to be taking a prenatal vitamin. Why are you supposed to take a prenatal vitamin? The number one reason is because of the folic acid. So you're supposed to be on 400 micrograms of folic acid for at least 3 months prior to doing prior to getting pregnant. And that's whether it's a spontaneous pregnancy or if you're doing a treatment. And that decreases the risk for certain types of birth defects, specifically spinal type birth defects, things like spina bifida. So prenatal vitamin is number one. My other just words of advice about a prenatal is please, and if you've heard me say this before, sorry to be repetitive, but redundancy is no sin here. And that is that a prenatal by and large is a prenatal. You do not need to overspend on prenatal vitamins. I have seen on the internet there are these $80, $100, $120 prenatal vitamins. And you think, wow, they're really expensive, so it must be so good, right? What I tell people is that if that vitamin can guarantee that your child will get a full scholarship to Harvard, then you scrounge the money and take that $100 prenatal. But pretty much most of it comes out in your urine. So I would recommend whatever you can tolerate. The $8 Walmart gummy is probably just as good as some of those more expensive prenatal vitamins. So the nuances with prenatals, some of them are formulated with fish oil in them or in a separate capsule that includes some fish oil or omega-3. And that is actually the number 2 thing on the list, omega-3. What else? Some of them are a little coated. They have a coating, so maybe they're tolerated a little differently in the stomach. They don't cause nausea. Some of them have a little extra B6, so they're supposed to help you with nausea when you get pregnant. But really, for the most part, a prenatal is a prenatal. Some of them have methylated folates, but by and large, the cheap one is just as good as the most expensive one. So please don't overspend on a prenatal vitamin. When it comes to fish oil, the thing that makes and fish oil, by the way, is sometimes called DHA or EPA or omega-3. DHA is not the same thing as DHEA, which is something different, very different entirely. But the thing about fish oil is that it literally is the oil that most of the time comes from a sardine. And so what you want to do there is to make sure that you get the one that says that it's odorless or burpless, because the first time you burp it up may be the last time you will allow one of those capsules to pass your lips, because it's pretty horrific. I like to tell the story that when I had first read, and this is many, many years ago, some of the benefits, the advantages of omega-3, I'm like, oh, that's a great idea. I should take some. So I went to Costco, and at Costco, I found, there was like this 1,000 pills for 1,000 capsules for $1.99. And I'm like, oh, what a great deal. Costco special. Kirkland brand, I think it was, I took exactly one of them, and the rest of them were returned to the sea by way of the toilet because one single fish burp is enough to make the paint peel. It may ruin your relationship. It may cause the engine to fall out of your car. So odorless or burpless is an important thing. The burpless ones are either formulated to absorb a little later in your digestive tract, not so much in your stomach, but maybe in the small intestine, so that you're not burping it up. Or they're formulated with like sometimes a little citrus oil, like a little lemon oil, for instance. And so if you burp, you'll get some pleasant lemon flavor as opposed to the flavor of sardine. Let's see what else. CoQ10 is really probably the most important thing as it pertains to egg quality for IUI. 2 different types of CoQ10. Make sure that you are getting enough CoQ10. The most common form of CoQ10 out there in supplements now is called ubiquinone. And just remember, none None at the end of it. Look on the label. It's ubiquinone. It'll say CoQ10 supplied as ubiquinone, and it'll tell you how much is in there. You need that type has to be converted in your body in order to make it work. And so 600 milligrams is what you need for egg quality there. 600 milligrams or 300 milligrams twice a day, kind of in a divided dose. And so those are the three kind of most important things: the CoQ10, the fish oil, and the prenatal. There are a few other things on the list: N-acetylcysteine, alpha lipoic acid. These are both really good things to take as well. And believe it or not, melatonin. Melatonin, you say, man, I sleep just fine. I don't need any extra melatonin. But the melatonin actually is helpful because higher quality eggs in the ovaries, in that fluid that surrounds those eggs, have a higher level of melatonin. So by increasing your melatonin, you may make for a healthier follicular fluid to contain your eggs and maybe better eggs. So those are really the things. That's the egg quality supplements for basic fertility. Anybody who's trying it at home, anybody who's doing ovulation induction with an IUI or even timed intercourse, and even basic IVF with a normal ovarian reserve. Those are the ones. But best of luck, Maddie. I think that this is going to work out great for you guys, and my fingers are crossed for sure. Brienne is here. Hello, good evening on the Facebook side. Do you recommend a fully medicated cycle for patients with endometriosis? I've read that adding estrase is not great for endo and it fuels it. I had a modified natural cycle result in a pregnancy of unknown location that required methotrexate. My next cycle, we're trying fully medicated with no suppression prior to. Well, so here's my concern there. So the first thing is, I don't believe, Brienne, that there's anything about the type of cycle, whether it's medicated or whether it's modified natural, that it has a higher risk for an ectopic. And when you talk about a pregnancy of unknown location, that means, well, your betas kept going up, but you weren't really sure where the pregnancy was. Was it in the tube? Was it in the uterus? You never got to see it by ultrasound, so you ended up having to get treated with that methotrexate. What I tell you there is, first of all, that the modified natural that you did resulted in a pregnancy. So to me, I'd say, well, gosh, that's a pretty good thing. You got pregnant with it. The problem was the pregnancy itself. It was not the protocol. There is no evidence that says that the protocol you use results in a pregnancy loss. And the fact that you got pregnant with that modified natural, which I think is an easier way to cycle anyway, says that worked for you. So the first thing I wonder about is, well, why change that? Because if it worked, it did a good job. It did what it was supposed to do. The pregnancy itself just wasn't able to keep growing. But again, that wasn't because of the protocol. So that'd be my first question. And the second thing that I'd be concerned about is not so much the effect of the medicated cycle on endometriosis, because you know what? You're going to get pregnant, God willing, fingers crossed here. You're going to get pregnant and your estrogen levels are going to be through the roof, sister. So you're going to have much higher estrogen levels. It really, the estrogen that you get as part of that medicated cycle is enough. It really mimics your natural menstrual cycle. So estrogen levels are really pretty close to about the same, just enough to get you to grow a lining. So, except if you did that modified natural with letrozole, that lowered your estradiol level, which, could have been a good thing there for you. But no suppression before getting pregnant. So you're known to have endometriosis. And endometriosis is known to stand in the way of pregnancies being able to implant. So it makes me a little concerned about, why you guys are making those decisions. They don't necessarily make a whole lot of A plus B equals C here to me. If it were me, I'd say, well, gosh, all right, you're known to have endometriosis. I would want to suppress you in all probability. Now, there are some nuances there. There might be times if you just had surgery for endometriosis, well, maybe you don't need suppression, but the modified natural, it worked for you. So why shift it? I don't think that had anything to do with the pregnancy working or not. But to answer your question, I'm not so worried about the estrogen and its effect on endometriosis. I'm worried about the endometriosis and its effect on getting your pregnancy to implant. You know what I'm saying? And just by way of understanding there, let's say that we have a euploid chromosomally normal embryo. All right, that chromosomally normal embryo gives you about a 65% probability of pregnancy. If you've got endometriosis that is manifesting itself in the uterine lining by way of a marker that's known as BCL6, then that 65% number drops down to about 8%, a little less than 10%, unless you suppress the endometriosis, and then that 8% goes right back up to 65%. So I'm kind of concerned about that. So I think that might be worth looking at there, friend. Let's see. Hey to Aaron, if you're still here, you're usually here for about 10 seconds and then you log off. Nat Gay 3, howdy. Hello, Mrs. Anita in South Florida. Good evening to you. Thank you for being here on this busy week. Happy Tuesday, Doctor. Wonderful, she says. Oh, you say all the right things. I appreciate that. Priest Lana says, I'd like to ask, how effective is biome testing, and would it be helpful to try to increase good bacteria before an FET? And in this mom who is advanced maternal age. Well, I got to tell you there too, and I hate to, I don't want to rain on anyone's parade or pee on anyone's parade either, but I'm not a big believer in that microbiome testing, the Emma and the Alice, because there just hasn't been amazing evidence to support it. It seems like a good idea. You know, it seems like a good idea, but there are a lot of things that seem like a good idea that once you actually do them and test them, well, it turns out that they're just kind of a way to kind of get you to part with your money. So, you know what I do that I think is a little better than the Emma and the Alice? I like to take a little sample of the endometrium because I do want to know if there's chronic inflammation in the lining there. A lot of times what the Emma and the Alice are testing is a vaginal microbiome, not actually anything uterine. And the vaginal microbiome, I really just, I haven't seen data that says unless you're really out of whack, if you've got bacterial vaginosis, you've got a bad odor or something like that, that you've got an overgrowth of one of the normal bacteria there, that can be a problem. But I like to take a little sample of that endometrium and I actually culture it. I send it to Quest or LabCorp as an aerobic and anaerobic culture. So we'll see what's actually growing out in it, that we don't just get a marker that says positive for plasma cells and, oh, we're going to give you some random antibiotic to try to fix that. We're not doing something that's going to really be testing from the vagina. It's going to test from inside the uterus. We'll know what's growing there. And guess what happens? Your insurance covers that test. You don't end up having to pay the $500 or whatever it is for the Emma and the Alice test. So to me, honestly, Priest Lana, that's a lot more meaningful. The whole process is expensive enough that I hate to try to make people, spend more money on something that isn't really truly going to make a difference, not just because it sounds like a good idea and it's marketed heavily to people who want to be pregnant. Because hey, if it's a good idea, people will pay for it. And I just feel like it's part of my job to keep you from having to spend on stuff that isn't really truly been shown to be helpful. And that's my 2 cents worth on that. Hey, it's just half past the hour here, and you're watching Fertility with Fink and Friends live from Pensacola, Florida tonight. I work for New Life Fertility in Pensacola and for the Missouri Center for Reproductive Medicine in St. Louis and Tulsa. And it's great to be here. And this is the time during our weekly broadcast where we do what I call the 5:30 Fuzzies with Fink. The Fuzzies with Fink, and it's not just because I have all this extra hair. It's because we want to send out some warm fuzzies to the people who need it tonight. The fertility process is an arduous one. It's difficult to go through. It can be hurtful. It can be very frightening, not knowing what's happening to you next. It can be painful. It is expensive. It's an emotional roller coaster. And most of all, it can feel very, very lonely. It can feel like you are the only one who is going through this process. This is the time during our show where we all stand together as one community so that each and every one of you out there knows that you are not alone. It may not be about fertility. It may be about family. It may be about work. It may be about school. It may be about relationships. All these things are the speed bumps, the obstacles we face in our lives. And they're a big challenge day in and day out. Well, at the time for the Fuzzies with Fink, we stand together. We send out all the good vibes to everybody tonight who is hurting, to everybody tonight who is sick, to everybody tonight who is worried or anxious or depressed or just not sure what happens next. The most important thing for you to know is that we're all in this together, that you are not alone. And as I am fond of saying when we close our program, tomorrow is a new day and it's full of all new adventures. So every step forward with hope. And please know we're all here. We're all here with you. Let's break the internet with kindness, put our arms together, and send out the warm fuzzies tonight to everybody who needs it right now. Thank you. That is the 5:30 Fuzzies with Fink. And if you have just joined, if this is your first time experiencing that, please come back next week, even if it's just for a few minutes before the bottom of the hour, because the more people we have, the more of that positive energy we can send out there. And I really do think that's something that makes a difference. I really, honestly, truly do. Is it possible to do breastfeeding and take Oralissa at the same time before transfer? No, it is not. I would not do that because Oralissa shuts down the hormones in the pituitary gland, and one of those hormones is prolactin, which causes your the production of your breast milk. Now, if you're breastfeeding, some of that reflex between the breast and the pituitary gland may keep that going, but then you're also going to be secreting some hormone blocker, which is what Oralissa is, into the breast milk, and the baby does not need that. So please do not take Oralissa at the same time as breastfeeding. Oralissa is one of those medications that we can use for suppression that we talked about for the endometriosis. Good question, though, there. Hey, Midgie and Jody Hoffman, if you're really on, you probably too, you showed up here for a second and then you logged off. Jody is my old redheaded friend. She's not old, but my redheaded friend of days of old, who lives in Missouri now. And we miss you very much, Jody. You are truly a special human being. Let's see. Angela is here tonight. Hey, Angela, why would there be bleeding or spotting after a saline sonogram? I've had 6 of them. So you're like a professional. You should do your own saline sonograms and maybe you'd get a discount, actually, you know? And if you can do the ultrasound with it, they'll probably pay you. I'm just saying. Only the last one was there's some small blood clots after 2 to 3 days. Well, you know what's happening there? It is that, you use some fluid to look around on the inside. And a lot of time that fluid just still hangs out in the lining. It mixes up with all that extra tissue on the inside and decides to come out. A little bit of fluid goes a long way. So I would not be at all surprised that there was a little bit of bleeding in the days after a saline sonogram. Sometimes even the catheter that goes inside can dislodge a little piece of tissue, and that can create a little more bleeding. A little bit of blood, this much blood creates a clot that's this big, and so it's got no place else to go really but out the door. So I would say, Angela, that's probably what that was all about, I would think. Noodles asks, is there any harm or risk in moving embryos around to a different clinic? Is it all embryo move, or can it be done just one? Is there a risk for moving it multiple times? Well, so you know what happens when you ship an embryo is that they pull it out of the cryo storage and pretty quickly put it into a new or portable cryo storage tank. Then it's shipped. That cryo storage tank, in theory, should stay frozen. It gets to its new location. Somebody reaches into it, pulls it out of the transporter tank, and puts it into their more permanent tank. Well, it just depends on how long it's out of cryo from the time it goes from frozen to shipping container, and then from shipping container to frozen. In theory, that should be only a matter of moments, but I have seen problems. I have seen tales where the embryos come out and somebody gets distracted and they're out for a little too long. And that can be a problem for an embryo because we don't want them to start to thaw and then get refrozen. So in general, it's considered to be a very safe thing. And in fact, we know that thawing an embryo, freezing an embryo and then thawing it, has a success rate of really greater than 99% in most cases. So it usually is a very safe thing. I would feel comfortable in shipping them wherever you have to ship them, although I wouldn't do it willy-nilly. I would do it with a purpose. If you've moved or you've changed clinics or you decide you want Dr. Fink to transfer your next baby, then I think that's a very legitimate reason to do it. You don't do it just because, the place that I'm storing it charges me $600 a year, but the next place charges $575. So I want to save $25 a year. I wouldn't do that because realistically, the cost of transporting that embryo, you got to rent the transport device, you got to pay for the shipping and all those other things. So in general, keep them where they are. But when it comes time to, if your clinic stores them off site, when it's time to do your embryo transfer, they're going to ship them back there anyway. So I think it's okay. Can you ship just one? Usually they ship them all, just because, although I suppose that you could say, I only want them to ship 2 of them. I prefer, if there's 2, that we have 2. I think usually they all kind of want to go together. But let's say that they go to thaw the one on the day of transfer and something happens to it, or they look at it under the microscope and this embryo it just wasn't frozen properly the first time. The embryo is not good for you anymore. Then you still have an embryo to transfer. You have something else that they can thaw, and it's not an unrealistic consideration, so I do think about that. Let's see, we have Bree Mangum here this evening on the Facebook side. Is brown spotting normal about 5 days after an embryo transfer? And I would say, what that could be, my friend? That could be what we call an implantation bleed. And that is, well, imagine that embryo is taking up residence in that nice, spongy, warm, juicy place that is the inside of your uterus, and it goes, think of it as going like splat in there, and some of that extra tissue, it splashes, it kind of starts to come off. And where does it go? It goes out the door. Brown usually means that it's a little older. It might have been sitting inside for a little bit before it decided to come out. But Bree, I would say that little bit of spotting 5 days after a transfer may be a very reassuring sign. So fingers crossed there For sure. Let's see. We've got Shada here this evening. Hi, Shada. Good to see you. Jess says, oh, yeah, we do love the beach here, but it's been cold. Yeah, it has been cold. And in fact, the beach, the water, they said the water, I think in the ocean's like 72 degrees. That is way too cold for me. I think if you're from up north and you come down to the beach for spring break and the water's 70 degrees, you're like, this is great. You go swimming. But those of us who live here, I wouldn't put my foot in that water. It's way too cold, way too cold for me. If you plug it in and just heat it up a little bit, then that feels much better for my taste. How do you feel about an unmedicated frozen embryo transfer? We did our IVF and plan to do that again with embryos, and no known fertility issues. I have 3 older kids, but I'm 36 now. So basically what you're talking about there is Jessica, you're talking about a natural cycle FET. And there's nothing wrong with that. Nothing at all. However, there is some evidence that doing a modified natural FET, which is where we give you a little letrozole to make sure that you're going to make an egg. And then we give you a trigger shot if you don't ovulate on your own to make sure that that egg gets released in an expected timely fashion so that we know exactly when to do your transfer. There is some evidence that shows that the modified natural may be a little bit better than just a natural cycle, but there's nothing wrong inherently with a natural cycle. Absolutely, you can do that. And here's the thing that's interesting, because I remember the first time I thought about it, I said, look, I was doing a lot of natural cycle FETs and I said, I don't want you to use letrozole. Just use your own cycle. You cycle fine. You have regular periods. Use your own cycle. Well, aside from the fact that sometimes, you get this kind of watched pot thing. The watched pot never boils. That may be the month that you just don't ovulate at all and you miss your time to do it. But my thinking was, well, gosh, why do I want to hormonally manipulate anything at all if I don't have to? Because the body does what it's supposed to do anyway. So why mess with it? It's probably going to be lower success rates when you put some letrozole on it for ovulation induction. But then there's actually some evidence that shows to the contrary. Doing the ovulation induction, make sure that you make a good corpus luteum, which is where you get your progesterone from, and actually has a little better outcomes. So now I favor the modified natural, which is almost a natural, but it's just kind of making sure the ovaries are going to do what they're supposed to do when they're supposed to do it. Yeah. Shada says, my prenatal is Thorn, and it says a serving size of 3 daily, but it takes you to 1,700 milligrams. Is that not too much? Well, it depends on, so the Thorn prenatal is a good one. So I actually keep that one on my list. It's price-wise, it's a mid-range. It's about $1 a day. I think that's a fair price, $30 for a bottle of prenatals, even though, like I said, you can do the one that's $8, and I don't think it's really substantially different. I also think it's hard to take 3 vitamin pills a day because it kind of gets down in here and it kind of comes back this way. And that vitamin burp thing is I don't know, is just not my favorite, to be honest with you. And 1,700 milligrams, well, it depends on 1,700 milligrams of what. I don't know what that necessarily means because it's going to be 1,700 milligrams of something. If it's 1,700 milligrams of folate or folic acid, that's way more than you need. You need 400 micrograms of folic acid. So there are some prenatals that have 800. There are some that have 1,200. And guess what you need? 400. The extra in most people is not helpful. So I think, Shada, it depends on what that 1,700 milligrams is of. But yeah, I think it's a little, 3 a day just seems like a lot. Rice Ninja, I like the name. That's awesome. Question, Shada, are you at MCRM only on Fridays for visits? Yeah, I do remote visits on Friday afternoons at MCRM, and I am there for retrievals, and I do transfers in Tulsa. Let's see, Shada says, do we need to have bright red blood each cycle to call it a period? Or could it be just light brownish flow or spotting for a period? Some people will only get spotting for their period. And so I think it depends on what's normal for you. Normally we say cycle day 1 is going to be the first day of flow. Now, what happens if you don't get flow? If your period is spotty only for a few days, then I think that first day of spotting counts as cycle day 1. So it's kind of whatever is consistent for you. And bright red is not necessary. Brown just means it sat around a little bit before it decided to come out. And there's no inherent problem with that. I would also say there is no inherent problem with a period that's a little shorter. Like you say, well, I used to have, and I hear this a lot, I used to have 7-day periods, and now they're only 4 days. And so I'm worried that that means something is wrong, or my uterus will not be able to hold a baby. And there's no correlation to that. And that just has to do with kind of how quickly the hormone levels drop and then come back up. So, and how heavy it is, if it's not heavy, I think that's actually probably a good thing. Heavier is not better. And some people just have very light periods, and some people have very heavy periods. So just as an aside there. Let's see what else we got going on here. You are welcome, Bree. I'm happy to help there. E. Winnick, good evening to you, NGPTV. Hi, Rachel Bowes. Oh, and yeah, Aaron says hi for 15 seconds. My good friend Logan, the therapist, one of the finest therapists I know, who lives in Northwest Arkansas. Logan, I don't know if you accept remote patients or only those who are local that you can see in office. But I will say, as we talked about, this process is very difficult, and having someone to talk to about it who really understands the pressures and the discomfort that goes along with everything that is fertility, all the way from the relationship side to, the being pregnant side. Logan has really impressed me with her skills as a therapist. So Logan, the therapist, is the handle. Reach out to her on Instagram. Hi, Sarah, good evening. And Angela asks, going back to the bleeding with the SIS, my right side, the tube was open, the left tube was blocked, possibly with some scar tissue. Would this affect a frozen embryo transfer? And the answer is no. So when it comes time for that transfer, all we're looking to see is we want to know that uterine cavity is normal, right? That there is no scar tissue, that there's no fibroid, that there's no polyps, bands of muscle, anything that may keep your beautiful, perfect embryo from taking up residence on the inside. The tubes really should have nothing to do with it at that point. So you should be okay there. Hi, K.N. Davidson and Kowser. Good to see you here this evening. Hi, Stephanie. Reed says, Dr. Fink, I have an E-Shore. Anything that we should know we should do differently before transfer? We're using donor eggs. So E-Shore was a method that involved a method of tubal sterilization that involved placing a little nickel titanium coil in the opening of the fallopian tube, which then created an immune response in the fallopian tube and caused, over the course of really the next 3 months, they say, of that tube area to scar closed. It was actually really a great procedure. And those of us who did a lot of them and were very comfortable with them really believed in them strongly, because it meant that you could have your tubes tied in an office setting in something that took, only moments. that had a very minimal amount of discomfort that you could take a little oral medication for and do really great with, not have to have general anesthesia, not have to be intubated on a ventilator, not have to have sharp implements placed in your belly and things cut on the inside. So it was a great procedure. The problem is that the company that did the that owned Essure, they marketed it very, very heavily to general OBGYNs, which is fine because an OBGYN should be able to do a hysteroscopic operative procedure. But like in anything, there are variations of how good some people are with some things versus other things. Some people are great open surgeons or laparoscopic surgeons. Maybe doing hysteroscopic things wasn't their forte. And so ultimately what they found is that there were a lot of uterine perforations, which means poking a hole in the uterus with that little implant. There were migrations of that little coil. It could move to places where it wasn't placed. And so what ended up happening is, I don't think they actually took it off the market, but they made it very, very, very difficult to get. And so that's why nobody does, really Essures anymore, because you just don't, you don't see them. And that's really the reason why. In the right hands, an Essure was really a wonderful procedure. I think it was a great procedure. But so the scarring takes place. The little piece, the tip of that coil can still be inside the cavity. It shouldn't cause a problem. I certainly do think, Reed, that you guys should have a hysteroscopy to be able to look and just see what things look like inside and make sure that half of that coil isn't hanging out in the uterine cavity, because I have seen that. And as long as that's the case, then no, the Essure is okay and shouldn't need to worry about too much, except for there are a few supplements that are part of the evidence-based protocol for embryo transfer. And that is prenatal vitamin, vitamin D, vitamin E, CoQ10, fish oil, and something that's called L-arginine. L-arginine is the one thing that's on that list that's not on an egg quality list. L-arginine is actually not good for eggs, but it's good for blood flow to the uterine lining. I like to make sure that everybody having an embryo transfer is on those 6 things: vitamin D, vitamin E, CoQ10, L-arginine, fish oil, and prenatal vitamin. Yeah, good question there. Angela asks, do most embryos implant on the fundus of the uterus? The fundus is the very top. It's, if the uterus looks something like this, cervix down here, the fundus is this part here, or on the outside of the uterus, this part. And I would say no, not necessarily. It can implant really anywhere inside the uterine cavity. The uterine cavity itself typically measures, anywhere from probably 3 to 6 centimeters on average, I think, in most people. So anywhere in that space, on the top, the bottom, or at the fundus in there, the embryo can implant. So yeah, good question. Hey, Haley, good evening. Let's see. Marlena asks, Dr. Fink, how many days before an egg retrieval do you stop stimulation? Well, so when you're doing your stims, typically you get your trigger shot. That trigger tells the brain to tell the ovaries, we are coming for those eggs. And usually about 36 hours later, some places do 35 hours, some places do 37 hours, but on average, about 36 hours later, you have your egg retrieval. Now, there are some situations where people may continue to get a little stimulation after the trigger, leading up to the transfer, like maybe you get stims the next day. Or my rule of thumb is that if your trigger shot is happening after midnight, then I like you to go ahead and get your dose of stim medication that day. But trigger always happens roughly about 36 hours before retrieval. Where can you find that list? Read, if you want to just Instagram me, I will write it down for you. I'll send you the list, or I can even send you a link for it. Jessica asks, do you think that Omega is helpful? Omega Vin. At this moment, that is, I know the name, but I can't think of Omega Vin. I'm not sure if it's a vitamin. There is Omnitrope, which is growth hormone, which is controversial. Many of us think that it does something. And I just can't for the life of me think of, let's see, Omega Vin. I'll get you that answer in one quick second. But meanwhile, hi, May Denise, Mary June, Shalom, Elizabeth. Nice to see you this evening here. Omega Vin. Yeah, that's a thank you. That's and thank you, Shada. Yeah, it's a Omega Vin is one of the brands of what's known as intralipid. It's a brand of intralipid, and that lipid infusion is said to be, fish oil IV infusion. That lipid or fat infusion, omega-vin is one that comes from omega-3. It is said to be a potent anti-inflammatory. Now, the specific evidence behind it is that it is most helpful, or it is known to be helpful, in people who know that they have a problem with natural killer cells, or NK cells. And that's a hard thing to measure. There are some places, such as where I used to work, that recommended an intralipid infusion for everyone. And many people would think, I've got to have that intralipid infusion or else I'm not going to get pregnant. It is not an evidence-based approach. It is one of those things that, well, hey, we're going to do it, and it's probably going to help some people. We just may not know exactly who all those people are. So it's not going to hurt people. It wasn't super expensive. I think it was maybe $75 or something for that intralipid infusion. Maybe a little bit more. I can't remember. Omega-vin was something that I think a lot of insurance would cover as a brand. So it's certainly not harmful, but it's not the same thing as getting that fish oil as a part of the diet or as something that you would use for egg quality. But rather, it's like basically it's an IV version of the keto diet. It's like getting an IV keto infusion where the fat is said to be anti-inflammatory. So certainly I don't think it's harmful. Is it appropriate for everyone? No. Do we know exactly who it's appropriate for? Well, the problem is it's hard to test that. It really is. And so in most cases, we can't know. So I think it's okay to do for sure. Hey, Red Bear, good to see you. I hadn't seen you around for a while. Jessica said, oh, thank you for covering that. I had not heard of it used. Very common. It's in my protocol. I think if it's in your protocol, Jess, then I think it's okay. I do. And it's probably good for you. And on some level, it is not likely to be something that's going to make or break a transfer, something that's going to get you pregnant with an embryo that's not normal. Most of the time we sort of think that, gosh, the big problem must be something that's in the mom. It must be something about the uterus. It must be something there. That's why she's not getting pregnant. In most cases, especially as it pertains to an embryo transfer, the problem's in the embryo. 95% of the time, the problem's in the embryo, not so much in the mom. But we do all these things to mom just in case, but be realistic about that. Probably not going to be a huge factor, but is it harmful? I don't think so. Is it okay to go in a hot tub after an embryo transfer, like the hot springs in Colorado? Yeah, I think it's fine. You don't want to sit there until you're sweating and passing out. You want to keep your core body temperature. It's nice to sit in that warm water, and sometimes that water is hotter than others. I wouldn't, stay in it for an hour, but to get in and get out, be warm, feel it, that good, nice hot spring. I do think that's okay. Being in a hot tub, you can take a bath, you can take a shower, I just don't like, again, I don't like it to be so hot that you start sweating, your blood pressure drops. That's when it's really probably a little bit too much going on there. Let's see. Shada said, "Oh, thanks again. Thank you for for filling in. It's that lipid before FET. You are absolutely right, folks. We're going to be out of time tonight. It is so nice to have you guys here at Red Bear. It's great to see you again regularly. Thank you. I hope we'll see you regularly. Every Tuesday evening, this is the place with Fink and Friends where we can talk about all that stuff that's important. This is your safe place, and I hope it is as much your happy place as it is mine. From Pensacola, Florida this evening, please remember every step forward with love, every step forward with kindness. There is not enough kindness in this world, and every step forward with hope. Because tomorrow is a new day, and it is full of all new adventures. This fertility thing is not the book of your life. It is just a chapter, and we are going to rewrite that damn thing, huh? What do you say? Thanks so much for being here. Until next week, Dr. Randy Fink. Good night.